age-related macular disease. Remember that macula luda is a spot at the back of the eye, at that retina, and we're going to learn with the visual axis that is the exact point that you would like the light rays entering your eye to hit. And if you do not have it hitting exactly there, that was terrible grammar. Okay. If you don't have it, I'm going to be on that all day. If it doesn't hit the right spot, your vision's not going to be good. But as people age, the macula luda starts to degenerate in some individuals, and that's called age-related macular disease. And so the pigmented layer starts to break down. When you look at the abnormalities or the way it presents, they're going to retain their peripheral vision. But their central vision, like where they're looking straight ahead, it's like you can't see straight ahead, but you can see all in your peripheral vision. That's age-related macular disease. You have degeneration of the macula, and it occurs in two different forms. You have dry and wet. And dry is just where, as you age, it starts to atrophy and degenerate at the macula. The wet form is actually a different type of disorder where you have leaky vessels that are underneath that area. And so compare that to the dry form. The dry form, there's nothing they can do. It's just going to atrophy. Right? Without some type of new laser surgeries and stuff that I don't know about. Nothing they can really do about that. But the wet form, they can go in and laser those vessels and actually decrease your symptoms. Whether that comes back or not. Now, I'm in disagreement that they fix the air conditioning. Is it muggy in here, y'all, again? There's no. Cataracts. Cataracts is an abnormal discoloring of the lens of your eye. But what's actually happening is the proteins in the lens is becoming, they break down, they become faulty, and it is due to exposure a lot of times to UV light. But things like smoking, long-term steroid use, diabetes have all been found, chemicals. I don't need you to learn that list of what causes cataracts. Cataract, because it's not a clinical course, but I'm giving you examples that cataracts can be caused by these. So, smoking, hanging out down at the beach. Okay. That's actually not true because a lot of people who never did that and wore sunglasses all their life practically still get cataracts sometimes. And what they can do now, and it's kind of cool, and it's one of those things that drives me nuts. Like, I'm not going to Dremel your toenails. I'm going to leave that for a diabetic special. I'm just not doing it. Some people have no problem with take a Dremel, dust is flying off their toes. No, that's like nails on it. I don't even mind if you run your nails down the chalkboard. It doesn't bother me. But messing with your toes with a Dremel does. And so does when I was in phase 2. And I'm looking through, it's a double, you'll see a double scope in the OR where two people can look, one person's doing something, and I'm watching them do this cataract surgery and cut into their eye. I'm like, oh no. I don't like that idea at all. But I did let the same guy that was doing that do my PRK when I was in phase 2, which technically you weren't allowed to do, but I pulled that off. What's that? Yeah. Go over whatever side you want. Say this. Oh, gosh. It would help if you had a list of cataracts, you know what the lens was, right? All right, so we can't, let's see how we get this apart. It's in shambles. We don't need that part anymore. Okay, cornea is there. This is your iris. You can take your iris out. And just behind that, you have a lens. That would be your lens. The lens is the biconvex structure in your eye that allows you to focus or go through accommodation. In other words, the lens is what they call a variable refractive medium. And if you look at it, it's like an onion where it has multiple layers of proteins that they call crystallins. And so truthfully, when you do like a good example of the lens, and we're going to talk about the lens more Now, can anybody remember from yesterday what attaches to the peripheral edges of the lens? Well, the ciliary processes, but technically that's not attached to them. What comes off of the ciliary processes?
Zonular fibers.
Suspensory ligaments, zonular fibers, somebody said. Those are connecting. So all the way around the periphery of this, you would have these little fibers that come off of the lens and go to the ciliary process. Yes. And so those are going to allow, we'll see here soon, for you to adjust this lens. When you do, just for reference, when you do PRK or you do LASIK, we're going to take a flap and then we can, okay. That's not a good way to do the flap. I got the lens back. Now the lens broke. Okay. We want to look at our cornea versus our lens. I don't know why I'm getting into this. Your lens can be replaced, but that's not what they do during PRK and LASIK. So in PRK, like I had, your cornea does most of the refraction of light. So your vision, a large part of why you can see good or not, is due to the cornea. And so in PRK, they actually take a little brush, and you're looking up at this light, and that spinning thing, it abrases off the top epithelial layer so that they can laser the rest, and then they give you steroids so that grows back very slowly and doesn't scar. In LASIK, they actually take a scalpel, basically, fancy scalpel, and make a flap of that epithelial skin, then laser it, then it lays back across it. If you didn't know that already. So that's the difference. But the reason I talked about that is we're not really affecting the lens, though. Because the lens is just the focus part. It's like your iPhone camera can see all sorts of things, but then when you get up close, it gets blurry. And so at that point, the iPhone we say, well, it needs to focus. That's what your lens does compared to your cornea. The lens allows you to kind of fine-tune and focus things in. Okay, so that's the lens. Thank you. I didn't realize I missed that. If that gets cloudy, it's cataract. The lens is going to be a dividing point for the eye between these different sections. And they've worded these funny, I think, as I always think a lot of it is, because they called everything in front of the lens is called the anterior cavity. But everything behind the lens is called the vitreous chamber. So we're looking at these two sections. This is why I think it's worded funny, because the anterior cavity consists of two chambers. See what I mean? It's like they wrote it to confuse us. So the anterior cavity has an anterior and posterior chamber. And then behind the lens, you would have the vitreous chamber. I didn't name these. And so if we define out, though, the anterior chamber of the anterior cavity, that would be everything in front of the iris. So if we drew a line, our iris, our colored portion of our eye, and we took that out to the cornea, this whole area would be the anterior chamber. The posterior chamber would be behind the iris back here with the lens. And both of those chambers are going to be filled with the same type of fluid. That's aqueous humor. And aqueous humor is made by those ciliary processes of the ciliary body. Remember from yesterday, the ciliary processes are also capillaries there that produce aqueous humor. And so as the ciliary processes produce aqueous humor, it's going to release that because the ciliary processes are in the posterior chamber. So as it's released, it's going to come into that chamber, circulate around the lens, and then it's going to go through the pupil to the anterior chamber. And then it will be drained away. Now in pictures, I'll show you draining away. It looks like it's at the corners, but there are, go back to this. There are angles. So as the cornea meets up with the sclera, all the way around, remember this is just a cross section, all the way around here, there are areas called sclerovenous sinuses or canal of Schlemm that allow the aqueous humor to drain because it's continuously made. And so the anterior chamber has that canal swim that's at the angle of the eye, where the cornea meets the sclera. So that's how we get it back into the blood. Whatever, every 90 minutes, you don't need to order the time frame, but every 90 minutes or so that's replaced. If there's a problem with aqueous humor, you develop glaucoma, right? High intraocular pressure. If you have everything, there are different structures in the eye that contribute to intraocular pressure. Your anterior cavity or chambers are the variable because you're making aqueous humor. The vitreous humor that's in the vitreous chamber, you were born with. So that's not going to change. But if this gets too high, if your intraocular pressure goes too high, that's going to damage probably your optic nerve. It's going to put pressure back on the optic nerve, which is what happened to me when I had PRK. Is I think I'm too diligent. You know, the average patient, you tell them to put those, it had steroid drops. They say, okay, put the steroid drops in your eye this many times a day. But I wanted to make absolutely sure that it healed. You know, I'm that type of patient. You know, most patients are going to drop those drops and go on with what they're doing. But no, you got to let those things marinate, I think. So I would sit on the couch, I'd drop those drops, and I'd wait a minute or two and just let them really soak in. Wound up with I think that's why. Maybe not. It could have just been because of the drops. I wound up with steroid-induced glaucoma. So when I went in, I was working in the department, but I had an official checkup, and I said I can't. You know, right after you did it, I was 2015. Right now, I can't really see that well, and they checked. Oh, you're at 2040, and look, oh, you got glaucoma. And so give me some beta blocks. So he gave me some beta blockers to get rid of that, and that just made it worse. And it got to the point a few weeks out where I said, he's like, oh, we'll just have to keep doing these. I said, tell you what, why don't we stop all of them, taper off the steroid and get rid of it, and if we have to, we'll redo it. And a week after that, I was 2015. Once I got rid of it, putting stuff in your eye, maybe it'll be better. Anyway, I had glaucoma. I guess I could have gone blind. I don't know. Interesting times. But what is glaucoma? There are two types. You'll always need to know this even for the pants. Primary open-angle glaucoma, primary closed-angle glaucoma. Very similar. You have high intraocular pressure. We're looking at the difference in names to say, well, what caused it? So primary closed-angle glaucoma means that the angle there at the cornea and the sclera, where the canal of Schlemm is, that angle has decreased. Really what's happening is the posterior, I'll show you on pictures here in a second, the posterior chamber where the aqueous humor is being released to, you're producing a lot of this, and the iris has been pushed up and kind of closed off that angle, so it can't drain well. And in that case, you'll start to get glaucoma, high pressures. The other one is primary open-angle glaucoma, and that's due to the fact that the angle's open, but the canal of Schlemm actually has like a meshwork in it. A picture of Brillo sponge again. It has like a meshwork, and it just has a hard time getting through there. There's abnormalities in that trabecular meshwork, and so the angle's open, but why do you have glaucoma? If we go back to that picture, erase some. All right, so you have that aqueous humor that's coming in and filling this, and if it's pushing up on the iris, that's going to close this canal of Schlemm off. That would be primary closed-angle glaucoma. If we go to the other side and say, well, it's open, but it still can't drain very well, that means the angle's open, so it's called primary open-angle glaucoma. And we can look at this. You ever done an eye exam and you look for crescent shadows? That's what we're looking for. We're going to test them, probably their pressure levels. They do this every time you get an eye exam. They're both the same, but it doesn't matter because they're not both the same because it's an angle open, angle closed thing, but they're both treated the same. So we're going to give them cholinomimetics, which are cholinergic agonists that cause constriction of the pupil. When you contract the ciliary muscles, right, that actually will open the angle back up and kind of straighten out the trabecular meshwork at the same time if it wasn't, off, the angle wasn't closed. So in closed angle glaucoma, we're going to pull the iris away and open that canal slim by constricting the pupil. Like I said, in open angle, we give them the same thing because it actually stretches out the trabecular meshwork when you constrict the pupil. So we treat them both the same way. Kind of interesting. I'm telling you, it's as hot as in here when I left yesterday. Maybe it's just me. Maybe I'm getting sick. You're hot too. I'm glad y'all are in PTs. Dissecting kidneys. I can tell you the secret. You know what the hardest part of renal is? You want to know what the hardest part is? It's so convoluted. Okay. Vitreous chamber, sorry. It's Friday. I'm having a good Friday. It is Friday. Larger of the two cavities. So the vitreous chamber contains the vitreous body, or you could say vitreous fluid, right, which is a jelly-like substance. If you ever cut into like the cow eyeball or whatever we dissect, you can see that it has that jelly-like consistency. And it does contribute to interocular pressure, but its job is to hold and push against the retina. Well, it gives the eye and maintains its shape along with the sclera, but it's pushing and helping to hold the retina at the back of the eye. The vitreous chamber, the vitreous body is formed when you're developing, right? The embryo is developing, you form these. And so it's something you're born with, and I say that, well, that's why those kids, most babies you see, have big old eyes, right? Big old beady eyes. I mean, they're all cute, but they got big old beady eyes, right, compared to ours, because it's already there. Because it's a closed chamber, there are phagocytes that move throughout it and help to clean up debris so that you don't get things like floaters. And later you'll see, you'll study, like we're going to look at on the next slide, things like retinal detachments, where this hasn't held that there. I don't know if anybody will ever mention it to you again, but I do. The hyaloid canal is found here. It is transparent. You will not see it when you look in the eye because it's transparent. The lens doesn't have a true blood supply, but it had to have one to develop, and that's what the hyaloid canal was. It used to be the hyaloid artery that was in it. So the whole purpose of this slide is to look at, because you're going to study retinal detachments later, and it's important in understanding of where it attaches. So this area, on the next slide we'll discuss it, this white area that we see here is called the ora serrata. So there are attachments of the vitreous body here, all the way along. It attaches to this ora serrata. And then there are attachments back here at the optic disc. Right? Because the optic disc is a blind spot, but that vitreous body attaches there. And we actually can have that retina come loose and push in on that body and distort your vision. That's called a retinal detachment. We don't need to go into that yet because it's not something for this class, but it can happen. So the ora serrata, we'd say, is the junction between the retina and the ciliary body. If we go back to this, it does help to put back together what I broke and look at this eye if you really like to, because it shows you. It's brown on here, or purple, I don't know. And that's the ora serrata. So the ciliary body, if you look on this, it actually shows you the ciliary body's here, right? It's connecting to the lens, but then just behind that is the ora serrata, and then the retina starts where the orange is. This helps to kind of, if you're having trouble with the anatomy, to kind of look at it. Because 2D pictures aren't great. I think it's time to call it a day. It's getting hot. Cataract, these are definitions for you. Make sure, as you know already, I don't need to say it anymore. I will. I got real carried away, didn't I? I told you everything you need to know about ophthalmology in my definition. No, I can tell you the secret to ophthalmology. Ophthalmology, it's not called Ophthalmologies for Dummies, but I forget the book, and it's a little bitty pamphlet. And all the ophthalmology students use it, and it will have everything. I got to remember the name. It has everything you need for here, the pants. It's like the Ophthalmology for Dummies. It's a great book. If somebody's heard of it, you can throw it out to the rest of them when you get there. Maybe they'll throw it out there. That's who encouraged me to get it, was the person teaching ophthalmology. It's like everything the PA needs to know about it. All right, so we're going to go into vision here. There's a difference, anatomy of the eye, and then looking at vision. We have to start looking at light rays, and light rays go through any type of medium are refracted, whether that's air, water, the cornea, aqueous humor, vitreous humor, anything that it goes through has it potentially refracted. Refraction actually just means to slow the light down and bend it. Or better yet, it's better to say it, the process of slowing the light down will cause it to bend. Right? Like a prism. You hit a prism, things bend and shoot out of there. So that's what refraction is. Well, the eye can do that. So this is just the overview. We're going to talk about each one of these. So that's refraction. Then you have photoreceptors back at the retina. That is where transduction of basically photons, which are going to be the stimulus. But where transduction occurs is when light strikes the retinal photoreceptors. Then you have a neural layer of the retina that helps to send that signal back towards the central nervous system. We'll talk about each level, but basically through the optic nerve to get it out of there. And once it leaves there, it's going to go to the thalamus and then on out to the cerebral cortex so we can interpret what we're seeing. So that's a very broad kind of overview. That sets us up for where we're going to go through. So refraction. As the light rays start to travel, I got some really high-speed graphics. There's always coming up. Light's going through the air. It's starting to slow. It hits something with a different density like water, and it will slow even more, and that will cause it to bend. That's because light travels through different densities at different speeds. So if you look at the lens, you have a beam of light traveling, now you have to picture it as traveling towards your lens. In that case, it's going towards, remember I said the lens is biconvex. I would assume, I can't assume anything, that everybody knows convex, concave. Right? I always think back to a skateboard, skateboards that are flat versus sunk in a little bit. You can hold it better when you're skating, right? Skateboard's kind of concave, it goes in. Convex, it would go up. They use that word for the lens. The lens is biconvex. And so when these light rays are coming at a biconvex lens, when they strike that lens, the middle portion of that light ray, you notice this portion has already made contact with the lens. And because light travels through different densities at different speeds, that means that the light rays that arrived at the lens before the outer portions is going to start to slow first. Oops, did I skip two? So they enter the part, and then the remaining, those edges on this picture, will arrive at the lens slightly after that. So they continued at their original speed. But once they all hit the lens, they will arrive at different times, and it will cause the light rays to actually bend. And what we're going to see is that converges them. A lot of slides kind of spell this out, but I think it helps. And the reason that it converged was the timing of the different parts of that light ray and how it arrived at the lens. Because that middle portion got there first. So in that instance, you see the light's converging and it's focused by the convex lens. The concave lens is going to cause just the opposite. It's going to cause light rays to diverge. So this is a biconcave lens that we see here. There it is concave. And if we send light rays at that, the outer portions of that light ray will hit first, and the middle portions will hit next, slow down, and that will cause it to diverge. That is the whole basis, not the whole. That's a huge part of the basis of how we adjust glasses, how we use glasses to help us improve our reading. Now you could say, well, wait, why are we talking about so much of these light rays and you didn't mention the cornea? I mean, the cornea does cause it to slow. The cornea is actually the major refractive, does the major part of refraction of light entering the eye. But the cornea is not variably refractive. You can't vary your cornea. What's the only way we can vary our cornea?
Contact lens.
PRK or LASIK, right? I mean, that's in a nutshell. Can we, if you've never tried it, if you have bad vision, if you kind of just use your fingers and distort your eye, you can do that a little bit with your cornea and make it where you can see a little better. If you've never tried that, try it. Sounds funny. You'll see. Because you can change what you're I don't want to get it. You can actually help adjust where the light hits on the macula by changing the shape of your eyeball. Sounds crazy. Don't do it. I know you'll be doing it later while you're watching TV. Okay, so here's refraction. Light rays entering the eye first get refracted by the cornea. Now we're not going to talk a whole lot about the refractive properties of aqueous humor and vitreous humor. We're just going to assume yes, and we're not going to calculate this. We're going to look at why this is important. So we're going to refract them. So most of the refraction happens at the cornea and goes through the aqueous humor, vitreous humor. But where we want to focus in on is what's going on at the lens and how we can adjust that later. An interesting part is when you have images that are formed on the retina, because of the way the light rays enter the eye, into the eye itself, they're actually upside down and reversed left to right. So in this example, you have a tree. And what we're saying is the tree is upright out here. But the light rays from the top of that tree, when they get refracted, are going to strike the retina. I didn't even get close. Right. The bottom of that tree strikes the retina. So the image that is projected onto that retina back there is upside down and reversed left to right because of the way light rays enter. But luckily for us, when we're very young, your brain learns to figure that out. What's right side up? That's actually what's hitting the retina, the picture that gets there. So if you look at things that are like 20 feet away, and if you were to see the light rays coming into my eye as I look 20 feet away, they're going to be pretty much parallel. They're going to strike that cornea, lens, back to the retina, and be refracted. But until they reach my eye, the light rays coming in are parallel at about 20 feet, which is where we put the Snellen chart. That's why they have that distance. Anybody else ever realized, as they're doing the eye exam, that they've memorized the Snellen chart? Yeah. That's what I'm saying. It cracks me up that they still use that all the time. Then you go to the doctor and they throw you for a loop, right? Nowadays they throw up all different ones. I'm like, that's not fair, doc. Had that thing memorized. Or they throw in a, hey, do it backwards. What's the third letter in the fourth row from the right? Get out of here. I'm just trying to deploy. Leave me alone. Okay. At this range, at 20 feet, the ciliary muscles that attach to the lens with the zoning fibers, the ciliary muscle itself is pretty relaxed. Anytime the ciliary muscles are relaxed, the lens actually is fairly flat. It will never be flat. The lens is always biconvex. But when the ciliary muscle is relaxed, the lens is kind of flatter. I want to finish this thought and then we'll take a break. I want to get through accommodation. We'll take a break. So anything that's closer than 20 feet, the light rays coming into the eye are not going to come in parallel. In that case, the lens is going to have to thicken to focus the image properly on the retina. So we need to know how that happens. So the ciliary muscle contracts. Anything you're trying to look at closer than 20 feet, the ciliary muscle is going to have to contract. That will put tension on the suspensory ligaments, allowing the lens to assume a more spherical shape. There's your textbook part to learn. That reducing the tension on the suspensory ligaments allows the lens to assume a more spherical shape. To increase the curvature of the lens in that manner is called accommodation. You're accommodating. Your iPhone accommodates, you accommodate. If you need to read up close, 14 inches from your face versus 20 feet, the ciliary muscles are going to have to contract and reduce tension on the zonular fibers, which reduces tension on the lens. The lens will not be as flat. It will become kind of more biconvex, more oval. Right? And that will allow you to see up close. And it's because of the way it's refracting the light. 2 slides, and then we'll 3 slides, we'll take a break. Right. Okay, so here's a rudimentary pictures. You know how much I like rudimentary pictures. If you look at what's going on and how this works, it's a little strange because here's the ciliary muscle. The green all the way around, this is your lens, of course. Looks like an onion. The green is your zonular fibers. The ciliary muscle is kind of angled this way. So I want you to think about it this way. This is the ciliary processes where it attaches, right down here. But it's also connected. Remember back to the study of the choroid? And the choroid consisted of all that area back there, the blood vessels going around the back of the eye, and then they became, the ciliary muscle body was part of that discussion because they're connected. So I want you to think about it this way, is the lens stays fairly flat when it's relaxed at 20 feet. So if you picture the choroid is always pulling towards the back of the eye and putting tension on the zonular fiber. That makes sense? If it was pulling this way, the lens would be a little taut, a little tighter. And so the confusion is, when the ciliary muscle contracts, what it's actually going to do is it's going to pull this way. And if it pulled that way, what would happen to the zonular fibers if I told you it was kind of taut to begin with? You pull that choroid forward a little bit, and the zonular fibers would relax. And anytime they relax, it allows the lens to be more icon, more oval. Let's look at another picture. So you can read through everything on here. I love this picture up here. I think I put it in your study pics because it's a great example where you can really see the ciliary processes, the zonular fibers here are suspensory ligaments. You see your lens. Here's your iris. I think I had this earlier too. And so if you use this bottom part when you're studying it later, you'll see that whenever you muscle contracts, when the ciliary muscle contracts, the zonular fibers get loose and it becomes more oval. When you relax the ciliary muscle, the zonular fibers get tight, pulling this way, and the lens gets a little flat. This is the process of how we're going to do accommodation. And the last thing before break here is our near point of vision. The near point of vision is the closest that we can clearly see something with max accommodation. The lens adjusting itself like that is accommodation. So just like your iPhone, if you take it and you put it, now it's much better nowadays. Anybody remember like iPhone 3, 4? It didn't focus at all, right? You try to take a picture of a page of paper, wouldn't focus in on that very well. You'd have to be back here and then blow it up. I was all into phones back then. I got a version of every iPhone ever built. I used to do a lot of work on them for fun, but that's a whole nother story. I don't know how many TA students back then brought me their phone to fix it after I told them that. Like, stop. Your phone's going to focus though. Does it very well. Your eye does exactly the same thing. It's blurry, you get it close, and then it will focus in and you can actually see what you're reading there. Until you get to about 50. So that's called accommodation. But near point, if somebody says, well, what's your near point of vision? The closest you can read something or see it clearly with max accommodation. That's a textbook definition. All right, let's take a break. Get some fans. Turn them on. I feel like I'm back in Houston.
So it's I think what exactly it was. It was in the it was by her, like not by her. It was in the 40s. I can figure what it is.
So I'm trying to study for the last few exams. I couldn't read more than like 5 minutes. He told me the treatment was
It's a very you don't. Even there's one like study. Also makes it pretty cool. No.
I'm going to explain here why it won't make sense until I show you. Is that fair? I don't know why.
If I don't see the questions, the level one person would require you to grab it. Identify first slide. That's how many times or 3 times.
Your hair is normal? Yeah, exactly.
It says beads on that. Level question. Yeah, they're saying that. Yeah. Mostly I see it.
That means they can go all the way up.
Like, you know, she doesn't do anything because you're basically telling me to go. Well, I wait 2 hours.
I wear glasses now. When I started
They're probably paying about $130.
I didn't need vision correction because of my so they gave me something.
I've had haircuts and I just like shake it off. And then what it We're gonna do that. Probably go to. There's like a slide 200 is like get into visual pieces or something like that. Yeah, it's like 30 slides. Visual pack. Slide 200.
I've never had a magic in glass in a long time. So it's enjoying my life. Because that's the most important one. When I thought I'm like, hey, we're not going to so then I go again, I'm like, all right, each of these is like, and they're like, oh, we don't do this, and it's like last topic.
No,
That's like my biggest idea. And I never like
fast ones like check mark.
How's the family back? How is it like? Study room.
Yeah. So it's been better. Like yesterday, it was like, I can't do anything. So I found out at certain okay, dope. So, and then I was like, hey, like, look, actually back. And I like, we showed them, like, they still have the area. Look, that's your food. What? You guys, like, I had to kind of watch the baby. She actually wants to time on her everything. But what I would do, like, I would get something order, like, the boys are good. Like, ah, you see me pop up? Like, yep, I see you. So, I'm finding ways to still be productive, like, kicking it with them. But, like, still getting quality time.
Yeah.
Right, I had a really good time. So I was like, we need more. This is healthy for
She don't have to sing. Huh? You said the one I sent in the group. You see Miss America?
The price of Dippin' Dots with inflation
Yeah.
is unreal. So, for a brief moment, I was like, Dippin' Dots so good. But also, I thought in the back of my head, we win today, we win tomorrow, or tonight. We're going to be here another day. That's more for me. So that means I can buy my own Dippin' Dots and be able to. Does anything make you nervous? Caves.
Caves.
Nothing really. I mean, I don't see any caves. The sound, but it's not the desert. But,
In the desert?
pretty hard. Striking out the sun, not walking somebody, so I don't really get too caught up in all the sugar cap and all the mean things people might say to me because it's just, I think I'm a cool guy. My dogs think I'm awesome. My teammates like me. And my friends like me, so I'm going to attack you. I heard a man.
Caves. That's something that makes you nervous. I don't know. Case. Cat Williams. Yeah. That's not even Cat Williams. What? Cracker. He's like, I don't think they should have been on set. Dude, I don't know how he just says like off the wall shit. Like he literally just throws up whatever's on his mind.
I'm everywhere in that.
That's why I've done both of these things and jamming and I still needed to study. It's not like it helped me. It wasn't just better, but I didn't wasting time. So if I use my time to do this, I lost my file name.
I literally like last week.
Where are they at? There's three of them. There's one in China. There's one in. They said there's one in Iowa. Iowa? That's why I was like, how did they get this so far?
Just like small. But like, if I do that with my program, my brain line, I have to
All right, here we go. Here we go.
you can always add it later.
right. If I'm studying that,
Prayers by all people. Unfortunately, as you get older, no matter who you are, your lens will start to lose the elasticity that it has. And when it does that, you will start to lose the ability to accommodate. And when I was in PA school, I just told somebody this is a break, but when I was in PA school, I was in the senior trimester. We call them trimesters. And I don't know, I was 3 or 4 weeks out. We had like, I don't know, 3 or 4 exams left. And all of a sudden, anytime I would open the book, now we didn't have the slides. Like back then, they used slides and they would give you a book. I mean, we had thick books where they would print out the slides in note view. You know what I mean? The note view version of it, 3 on a page and all that. And that's what they would give you. If you went up and asked for a copy of their slides, they would tell you, not a chance in the world you're getting my slides. It's crazy thing. Now it's crazy thing that. And what I learned after I came back as an instructor is because a lot of them had what they're going to say at the bottom. Or some of them even had what they're going to test on at the bottom. I've never done that in my life. I'm like, why don't you learn your slides? But anyway, I don't need to read the bottom of the slide. But that's not my point. Point was, I had to read everything in a book. Every class had reading assignments. You hauled your books in and out of here. You couldn't leave them like on your desk. So we hauled big soccer bags in and out of here every day with those books. And you needed them at home anyway. And so you're reading your book every day. And I went to read, and all of a sudden I couldn't see anything. It was just a big blur. And I could read for about 5 minutes, and then I'd have to stop for like 30 minutes, and then I could see again up close. And I wasn't blind. I mean, I couldn't see up close. So I went to the eye doctor, and they said, well, you have lawyer's eye. And they said, it's your ciliary muscles basically now are tired. So you cannot accommodate. You can't see up close. And the only way you're going to fix it is you need to stop reading for a few weeks. You know, that's not going to happen. So that's the way I studied. 5 minutes every, like really, it wound up being about every 15, 20 minutes. I would read for 5 minutes, and then I'd have to do something else or listen to it. I needed somebody to read it to me. Either way, I made it through. What was hard was when I got to the test. I'd have to stop and focus off for a while, then go back to the question. I would try to do it between questions, close my eyes. Fun stuff. But that was because of the ciliary muscles. Developing presbyopia, everybody gets that as you get older. It's just going to happen. You know, younger people say never. Okay, it's coming. If you don't wear glasses at some point in your life, you probably will. And if you do wear glasses, you'll probably still wear bifocals, right? But presbyopia generally begins in people in the middle 40s who previously didn't wear glasses, and now they come in and say, I can't really focus on anything up close. Then we get into, somebody asked me about this at the break, and I said, well, let's talk about it. That's what we're just about to talk about. So we'll look at it there. So the normal eye is called emmetropic, normal shape. It refracts light perfectly. So any object that's about 20 feet away, you have a clear image that's formed on the retina. If you have a problem with where the image hits the retina, now you're going to have an issue. You're either going to have myopia or you'll have hyperopia. I say it backwards. Hyperopia, however you like to say it. Myopia is nearsightedness. Right? You can see things up close, right? But you can't see things go far away. When you have hyperopia, that's farsightedness, meaning you can see distance, but you can't see up close. And then you have astigmatism. Astigmatism just means that you have an irregular shape cornea, which is affecting your vision. So if we look at these in the cause, myopia occurs because the eyeball is too long relative to the focusing power of the cornea and lens. So when the light rays come into this eye, because the eyeball, let's picture the eyeball is just too long, when it converges and they come together, they're not making it. The focus point is at the end of the convergence, and now the focus point is in front of the retina. It's not hitting exactly at the macula luda, the central fovea. That's where we want it to hit. So the image is focused in front of the retina, and that condition is caused by either an elongated eyeball or you have a thicker lens. It can affect that. The way we're going to correct this is to use a concave lens. So if we give somebody a concave lens, glasses, right? It comes in, it's going to cause a little bit of divergence, and then it will cause it to hit the right part on the retina. Diverge it out a little bit. This is why when you're in there, this is the exact thing that the ophthalmologist or optometrist, whoever you're at, is looking at when they've got the little thing on you and they're flipping them. There's 1 or 2, 1, 2, 3 or 4. You know, they're flipping all these, and they're actually taking, if you picture the focus point on that picture of where it's at on the retina, they're moving it further back, rotating it sometimes if you have astigmatism. They're adjusting where that point hits. You know, and I don't know about you, but after 53 years, 3 and 4, they're the same. They're just messing with you. And I have 3 and 4. They'll do it to me like 5 times. Like I haven't answered. 3 or 4. 3 and 4. Like, dude, those are the same. I don't care what you say. But next time you go for an eye exam, see if 3 and 4 is different to you. It's always the same to me. 3 and 4. They all have the same tone, too. 3 and 4. Hyperopia occurs in the eyeballs either too short, or if you look at, it could be a thin lens. Doesn't have as much focusing power there. So the image in this case is hitting behind the retina. Is it really hitting behind the retina? No. But where it's focused, where it would hit, if you could get to that point with those light rays, would be behind the retina. So you need to move it back anteriorly to hit the retina in the right spot. And in that case, we can cause it to converge a little earlier. We can use a convex lens, because it causes convergence. And we can adjust the point to where it hits the right spot of the retina. Astigmatism is different because your cornea has an irregular curvature of either the lens or the cornea. A lot of times we're dealing with the cornea, and it causes objects to be just distorted, blurred, kind of out of focus, as it says. And the way we correct it is using a lens that alters the axis of the way light enters the eye. So people with astigmatism have a little more trouble, like especially with night driving. You know, I have astigmatism, but if you have glasses or things, a PRK that can help correct that. But just because you have an astigmatism, you don't have hyperopia or myopia, it doesn't mean you can't have like PRK and LASIK. They can still do it. There are other things, just to throw it out there, like have you ever heard some people go in to get, and actually you'll do this in phase 2 in ophthalmology, you're talking to people and you're like, they come in, they want to get on the list to do these eye surgeries, and then when they're coming back after they go get their exam and they look at all the thickness of their cornea and all that, they come back and tell them, well, you can't do it. Right? You can't do it. The cornea is too thin, we're not going to do PRK or LASIK on it. There's some people that aren't eligible for visual correction. Will continue to wear glasses. Not only that, I had PRK in 2004, and it's still good. But after I had a scar that went onto my cornea, now I have a little bit more astigmatism over there. So I actually do have, like I can use reading glasses. I don't really need them so much yet, but I've noticed I do need them. When I had all that problem, they gave me reading glasses. They gave me these, they are bifocals that you cannot see the line or whatever. But the top portion is not really an eye prescription. It's something they've done to adjust the light coming in up there so I can see better because of my astigmatism. In other words, I can read 20/15, 20/20 on it, but if they do that, it's a little clearer. So I let them do it. That's why I don't ever wear them. Who cares? If it's too small to read, I'm old. I'll take a picture of it on my phone. By the time y'all get there, all this won't matter. You have like electronic lenses and stuff. Who knows? Pupil constriction. But until then, you got to learn it. When you look at the pupil and it's small, it's contracted. It's allowing light rays to enter essentially more parallel than when it's opening very large or dilated. So we said accommodation is adjusting the lens, but it also includes the pupil. When you look at the pupil itself, all of that's called like the accommodation mechanism. How do we accommodate? Is the circular muscles of the iris are going to constrict the pupil as we change the thickness of the lens. It's going to allow you, it's going to attempt, as you come closer, it's going to attempt to adjust the lens, right, to allow you to focus clearly on the image in front of you. It's going to accommodate the lens. Well, at the same time, the pupil will constrict down to allow the light rays to remain more parallel. Right? We'd rather have them coming in parallel into the eye. Because the more parallel they are, the more likely when they're refracted, they're going to hit the right spot on the retina. That's kind of it, except for a couple of, for these, is I want to mention things like binocular vision. So many animals see one set of objects out of one eye and another set of objects out of the other eye, right? I kind of think that would be useful. I don't know why we don't have that ability, but they can look at two different things at the same time. So you could study and watch for the person about to knife you in the back, But no, we weren't born that way. Actually, if you look at predatory animals, they all have eyes that are facing front and they have binocular vision. That's a key thing. I'm sure animals that have eyes that see two different things would love to have binocular vision. It's going to work out much better for you because binocular vision gives you depth perception and it also gives you a 3D dimensional perspective. So an animal that has them separated doesn't have that 3D vision there. So binocular vision is resulting because the light rays, when you're looking at an object, the light rays from that object strike the exact same corresponding spot on the retina, but you're actually seeing the image from two different angles. So the brain's going to take the information that's coming into each eye, and it's going to provide what's called stereoscopic vision, seeing solid. And it's very apparent to do this is when you hold something up. If you take a soda or cup, whatever you have in front of you, you just hold it out there like 14 inches, especially if it has like writing on it where I can say, or see, in case, emergency. You hold it there, and you close one eye to the next, you'll notice that the actual visual picture you see out of each eye is slightly different. But once you combine them together, you're seeing solid, stereoscopic. It's where illusionists and things use these to trick your mind. The other thing we have to look at with accommodation is convergence. And I didn't spend a lot of time on this, but in order for the light rays to remain parallel, as you bring that object towards you see it, as it comes in, we're going to go cross-eyed, as we say, right? That's called convergence. And so your eyes will continue, as the light rays come in, to converge in so that you're continuing to make the light rays hit the same spot on the retinas. That's it, convergence. So you're going to test the combination convergence, right? We're going to, can you read that? Can you converge? All right, rods and cones. We're going to go through a little bit more today. I want to get to a certain spot we were talking about earlier. Rods and cones, when they looked at them under a microscope, that's what they thought they looked like. The outer segments, remember these are cells, but the outer segments of rods are kind of cylindrical. When you look at cones, they look like a cone. They're kind of tapered shape, as we see there. That's not the most important thing in the world. They're looking at where we find them and what they do is. So the two different types of photoreceptors, rods and cones, are distributed unequally on the retina. So cones are mostly centered around the macula luda and specifically the central fovea. So this area would be the central fovea. Now remember that cones are our most visual acuity, our color vision. Most of those cones are found here around the macula luda. Remember, we want to hit the central fovea with our light rays. Rods are concentrated around the fovea there, the foveal pit, but there are no rods found in it, but as it goes out towards the periphery, rods are going to spike, meaning you're going to have a lot more rods outside of that. Another place we don't see rods and cones is the optic disc, because the optic disc is a blind spot. Seeing where we're at. But as you look at a rod or a cone, we're going to pay attention to the outer segment. Rods and cones have photopigments. guess what photopigments really are if we go all the way back to block 2? Integral proteins. So they're photopigments. They're different than other cells. They have photopigments, and the end of the outer segment is next to the pigmented layer of the retina. That is where we're going to see, that outer segment is where transduction for vision starts. In other words, that's where we're going to cause the receptor potential. So the rods and cones are the receptor cells for vision. And they're layered. They call them pleats, but they're kind of layered. And anytime you see things layered or rugae, right, the mucosa things, you can increase the area available. So here we're increasing the available area to trap light. So the outer segments, when you look at cones, consist of long folded pleats, like fabric, they say. When you look at the outer segments of rods, they're still folded, kind of pleated, but they look more like a stack of quarters. Like if you ever, do people still, y'all's age wrap coins at all anymore? Like a wrapped quarter wrap? No, not at all. They just don't. Do you even use change? I mean, I do. That takes people off at McDonald's apparently. I give them change all the time. They get all lost in their head. They'll give you back crazy change. Like, that's $10 and whatever, 64 cents. You give them the exact change, and they're like, I'm dead. I want to go. Does the computer not tell you how much change to count out? Even though you think. I'm going to stop because there's no sympathy in this room for my feelings on that. Because a lot of y'all go, well, we carry a calculator with us 24 hours a day. Now, if you give somebody a 20, no matter what the change is, your brain should know what you should get back. You shouldn't have to look that up. Sorry, get mad at me for it. Get mad at me for it. I mean, I'm at Sonic, and they got the little change thing, and I'm like, I told this girl, 37 cents. You owe me 37 cents. She's breaking out her iPhone. Give me my 37 cents. I didn't say it rude like that. It's just funnier in here when you say it rude. It's going to be 37 cents. Okay. Sorry, I got off on that. I agree with you, though. You always got a calculator with you nowadays. The outer segment of each rod and cone, they look like a stack of quarters. That's what drove me off into that. Okay, outer segments of both rods and cones. When a photon of light hits that photopigment, it's actually destroying that part. And it's going to leave fragments, and the fragments are going to be phagocytized by the epithelial cells back here. So we're going to have light that strikes these photopigments. That activity occurs in what's called circadian rhythm. So rod tips are going to be phagocytized first thing in the morning, or in the middle of the night if the light comes on. Right? So in first exposure to light, though, you break down the rod tips. The cone phagocytosis is triggered by darkness. So as it gets dark, right, you're going to start to phagocytize those cone pigments because we don't need cones at night. Right? And this happens a lot quicker than we think. If we look at just an average photoreceptor cell, it's still going to have, it looks differently, but it's still going to have all the other parts of the cell that we would expect. It has a nucleus, it has a Golgi apparatus, mitochondria. Those are givens, as I said. We already know they're there. And it has an axon. The proximal end of both the rods and cones has a synaptic terminal. And so if you remember, we're going to get there again, but where is the photoreceptors, synaptic end bulbs are, what are they going to synapse with? Bipolar neurons. Remember that picture? That's what we're getting back to. And the reason I brought it up here is because light strikes a photoreceptor pigment in the rods and cones. That causes the transduction for vision because it starts there. What's the stimulus? The light. The light hits the photopigment, causes it to degenerate. That sets off a receptor cell potential in that cell, which causes it to release neurotransmitter to the bipolar neuron. So this is that cell sitting in front of the first order neuron. The bipolar then is the first order neuron. Make sense or no? I'm recapping. Okay, so photopigments, when you look at them, are actually colored integral proteins in the plasma membrane, both rods and cones. And so what I just described means they're going through a structural change when they absorb a photon of light. And so if you really looked at how they're set up, you have what's called retinal, a derivative of vitamin A, while they try to say vitamin A is good for vision. Retinal and opsin, which is a glycoprotein. So these fit together. The photopigment, I'm going to look at rods for a second. The photopigments in rods is rhodopsin, retinal, and opsin together, which absorbs blue-green light most effectively. I'm not going to ask you that. Blue-green light. That's just true. So there are different, when you look at the cones though, they have the ability, I want to reference why I said that last statement. I want you to think of rods as night vision gray. I don't want you to bring the color spectrum into your minds, because there is a whole talk we could do on ophthalmology and the color spectrum. But even when we get down here to the cones, I just want you to understand there are different absorption maximums for different types of photoopsin. So there's photoopsin 1, 2, and 3. I do not care if you can give me what's in parentheses. So if you want to line that out, go ahead. I just want you to recognize this. There is a color palette, right? Everybody's seen a color palette. And because of the combination of these different absorption maximums, we can see a range of colors. So the different types of color photopigments allow us to see different shades of green and whatever it might be. I want you to know just the overall concept, not the actual what's not photoopsin is yellowish. I know what you're thinking. Well, why you leave it in there? Because if you don't, people that are ophthalmology texts stuff, they start asking you during class about it to see if you know it. You got any ophthalmology texts that you ever ask them? No. They should be leading your study group, right? They're keeping it quiet. Screw them. Okay. In darkness. That's okay. They'll cover something only you know soon. Don't help them out. I'm just kidding. Stop being retinal. I know y'all are retinal ready for this thing. This is interesting. In darkness, retinal has a bent shape. It's called cisretinal. Opsin and retinal fit nicely when retinal is in its cisretinal form. Once cisretinal absorbs a photon of light, it straightens out to become a shape called transretinal. This conversion from cis to transretinal is called isomerization. Now don't worry, we're going to go through this on a picture too. So in the straight, when retinal's in its straight form, retinal and opsin don't fit together anymore. They dissociate. The process of retinal and opsin disassociating is what ultimately ends in perception or vision, perception of vision, or perception of that individual photon. Another way to kind of say that is once light strikes a photopigments, it's going to cause them to disassociate. That's the immediate, that's where we're talking about transduction just occurred. It's called isomerization, but when light strikes that photopigment, that's going to occur. So after the light-induced isomerization that caused retinal to go from cis to its transform, curved to straight, it will decompose. Be phagocytized by the epithelial cells there in the retina and be reused. The photopigments have to be reconstituted or reused or you would lose your vision. So that's called regeneration. So you don't think of it on this level a lot, but all of the light that's coming into my eyes right now is hitting photopigments that are going through isomerization and being regenerated constantly. This is occurring. If it wasn't, right, you'd wake up in the, I'm trying to tell you this example doesn't make sense. You'd wake up in the morning and at night you didn't need all these cones. right? You're going to need them during the day. So cones are regenerated very fast in the day. But if you woke up and it was very slow and overnight you had a lot of them ready, right? I'm just being facetious. 2 hours into the day, you lose your ability to see very clearly and in color. They're constantly regenerating. Constant. So here's a picture to help understand what all those fancy words said. I think you'll understand this better. And I'll give you an analogy that's probably mildly inappropriate. Rhodopsin has a normal reddish color. Great. Okay, that's fine. The reason we want to say that is because when you go through isomerization, they actually call this like sometimes bleaching of the photopigment. Because in the presence of light, cisretinal is converted into transretinal. In other words, light struck a rod or a cone, right? So now, once it straightens out into transretinal, if we follow this, the light's going to come in and strike cisretinal. That will cause isomerization of retinal, and that will straighten out. Right? Retinal will become its transretinal form. In that form, they can no longer stay associated, so they will disassociate into transretinal and opsin. That's actually called bleaching of the photopigment. The enzyme after that's going to come along and convert transretinal back to cisretinal. Once you convert transretinal back to cisretinal from straight back to curved, then you have retinal and opsin can kind of get together again. They can reassociate and now form a new functional photopigment. That is called regeneration. So my inappropriate analogy is that if you have retinal and opsin in a dark bedroom and they're not married, I don't know. They're married to somebody else. And somebody else comes in and it's dark in there and they're cuddled up. When retinal's in its cis form, they're in that dark room cuddled up. But if somebody else comes along, opens that door and flips on the light, what are they going to do? They're going to disassociate very quickly. Right? Retinal is going to, if I'm retinal, I'm going to kick my legs and I'm going to disassociate with opsin very quickly. This was not me. I don't know why I just threw me into this. This is not a true story. But, I don't know. I'll finish it out. I'm trying to think of a way to finish that out. You get the point now. How do they get back? Well, the person who opened the door realizes, turns on the light, sees them, and if it's me, I just cashed in. Turn off the light, shut the door. They can associate all they want. But I'm going to my lawyer and going to the bank. That part's true. Right. I'm going to get there before you. Tell y'all too much about myself, because I'll tell you what, when I was in high school, like a lot of y'all, I would consider myself like I went out with somebody, like a pretty jealous type person back then. But years and years, a long time ago, I completely lost that. It doesn't even cross my mind. It's never crossed my mind in 23 years of marriage. You can go where you want, do what you want, because I'm not going to, I learned a long time ago, I will not worry about you cheating on me. I will not. Because eventually you'll get caught. And if you have to be with somebody that every day you have to worry about, you have to check their phone, you need to leave them. Sorry. You should not have to worry about them. Maybe it's because I've learned to focus in on myself too. Hey, I'm married, love my wife. You want to leave me? Sorry, I'm going to move on. I mean, I'm not going to be crushed. I know that sounds terrible. Actually, I would be crushed mentally, but I know that life goes on. That's the plan. Sometimes I don't make my points good. Sometimes I shouldn't even be talking about it. But my daughter broke up with one of her boyfriends this weekend. I did get on her. Well, she's going out with somebody else now, and I said, when did you, I like that kid. I said, when I just told him I thought we should. Nowadays nobody dates. They're going out, he's bringing flowers, they go out all the time dancing things, but they weren't dating. I'm like, you're dating, or he wouldn't do that. Anyway, she told him, I don't think we should hang out anymore. And I said, what did he say? She goes, well, he just answered back. I said, answered back? I said, you texted him and told him you don't want to hang out with him anymore? She said, yeah. I'm like, wrong answer. That was a 30-minute conversation. You do not text somebody that you're leaving. My goodness. It's high school. Odds are in 2 weeks you'll be back together with them. Okay, right. Sorry. Put it on the critique. I didn't mean that. Y'all did kind of need it because I was looking through slides to figure out where I was going because y'all are out loud there. Photo pigment, close my eyes. Your only thing you can think about is I want to use my rods. So when you're in the light, the photo pigment gets bleached. We're not going much further. Regeneration is too slow in daylight for the rods to keep up. The rods do not generate as fast as cones do. So rods don't have a lot to do with daylight vision. When you look at the cone photopigments, though, they regenerate very quickly. So there's also a form of cisretinal where they're associated available. So when we go back in the military, we call it losing our night vision. Right? When somebody pulls up to the FARP site and they are driving around with their full headlights on, or they pull up to you right as you go up to them and they turn them on, and you try to keep one eye closed at least because they just blinded you. They bleached all of your rods out right then. That's called degeneration. We broke them down. And it's going to take, rods regenerate very slowly compared to cones. So if you lose your night vision like that in the middle of the night, will you start to be able to see good fairly soon? Yes. But nothing like after about 30 minutes. Now you can really see. So a lot of us understand that. You lose your night vision. That's why you lose it. The other thing we can talk about is color blindness. Color blindness is the inability to distinguish between certain colors. It can be genetic. It's not something you normally develop later in life. I guess that's possible, but most common is red-green. In the military, that's a big deal. Maybe not as much now because I was in the military, 90s all the way up to 2013, and when I started in the military, I remember about 5 years in, they gave me this thing, and it was an old version of GPS. I don't know if any of y'all were around back then, but there was no real, it had a screen, but it was like those old video games on a Commodore VIC-20 that didn't tell you a whole lot of info, but it could kind of give you an arrow where you needed to go. Yeah.
Dag.
They
still use those.
It's terrible. I just use my iPhone. Yeah, my goodness. That's like they invented. Anyway, I don't want to get such a long time ago. Anyway, my whole point was we have those ability to walk around and use those things now. But why, years and years ago, especially if you're in infantry, but all military I think should be able to, but if you're infantry, why do you need to not be red-green colorblind? Yeah, red lens on a green map. You can't read a map. A lot of people can't read a clock nowadays, so I guess we're just going down.
Oh boy.
So let's have a little fun, and we'll finish it out with this. Color blindness. Now, on your phone, on your computer, your iPad, on a printout, that does not test your color vision. This is just a screening tool, and it's even worse when it's on a computer screen because it can vary in the clarity. So you can't base whether you're colorblind on this. But it's fun.
That was a 20.
You need to get the actual
too.
smelling charts for whatever. Color code. So what's A?
29. 70.
Yeah, 29. What's in B?
Where's 20?
45. If you disagree, yell out. It's kind of fun.
The first one's 70.
7.
In pink, yeah. 70 in pink. There's a 70 and a 29.
Yeah, 70, right? The bluish color to it.
Yeah, the bluish one.
Yeah. That's why I said if you yell it, call out. Different people see different things. Right?
There's nothing.
What is C?
45. Nothing.
5. What do you mean 5?
There's a 5 right in the middle.
That always starts the discussion.
There's blue 5.
I see a candlestick.
I got some sort of weird pattern.
She said,
Early 2000s trial.
How do you see a 5?
Yeah, I can.
Now, those of you who didn't,
We
if
should
you
borrow
raise
it.
your hand, if you're enlisted, you're out of PA school. Because you still have to pass another chapter 2 at the end of this thing. Just kidding.
I got a waiver.
Yeah. Let's hope they honor it for the next.
That's pretty good.
They don't worry about this as much as they used to. Whoops. What was D?
26.
What does it mean if you can't see the 5?
Nothing.
Okay.
Uh-oh.
It's fine. It's not. And that has
I'm just
nothing.
saying for somebody who might not see the 5. What would it be?
Okay, I'll stop with this for the day. About 4 years ago, I was doing these, and that's when I wrote the "What do you see?" so we could have a little fun going through there and explain these are not technically going to be. It may have been longer than that. Things, the older you get, the more time is like, that was just last week. Like, no, that was last year. I'm like, you're right. But a long time ago, I was talking about this, and it's probably 2016. And I said, go through these, what do we see? And we went through each one of these exact ones. And I said, now listen, back then it was still around that if you're red-green colorblind, and you apparently still do, you're going to need this waiver. But they weren't as forgiving back then, and I would tell them, talk to me after class, and I'll tell you how to make sure you pass that physical when you get to phase 2. But so we had a little fun with it. But for fun, I threw one of these on the test and asked them what they saw.
Oh.
And one person missed it. You know, like everybody saw A, right? Don't answer that if you did. And everybody went, oh yeah, that says this, or I don't know which one I threw on there. And it was just a gimme question, just for fun, because of the conversation that day. And somebody missed it, and I'm like, I don't want to know that. I really don't want to know. I had to give the whole question to them then, right? Well, to one person. That's not fair, because I just told you that's not a real test. I did tell them, come find me, I'll talk you through that. Then I thought, knowing just like y'all, if I did that to y'all, and I'm not going to, so don't get excited. One of y'all would miss it just for fun. He was probably that kind of person. All right, sorry, we got a little off track today talking about crazy things. Either way, I'll finish it out saying I really do think that questions should be grammatically correct. Y'all have a good